Hello, pharmacists and friends. Today is April 25th, 2023. Welcome to the Regimen, where public health pharmacists, pharmacy students, and our guests discuss the latest public health issues. Listen to find out how pharmacists and pharmacy students like me can improve population health, health equity, and patient care through advocacy and education. My name is Brindley Rospars, and I am a final year pharmacy student at the University of Rhode Island, working with the Rhode Island Department of Health alongside my professor, Dr. Bratberg.
Hello and welcome again. I'm Jeff Bratberg. I'm a clinical professor of pharmacy practice and clinical research at the College of Pharmacy and the academic collaborations officer at the Rhode Island Department of Health. As a reminder to our listeners, the opinions expressed in this podcast by the hosts and guests do not represent the opinions of the United States government, the Rhode Island Department of Health, the Missouri Department of Health, nor the University of Rhode Island.
We are thrilled today to be talking about a very impactful topic relating to public health, which is community health workers and their rising role in the pharmacy setting. Today, you can expect to learn more about what community health workers do to impact social determinants of health, their impact in communities, and how to utilize those services in the pharmacy setting. We are very happy to be welcoming Dr. Annie Eisenbeis, PharmD, MBA from the Missouri Pharmacy Association to the podcast today.
So Dr. Eisenbeis is the Director of Practice Development at the Missouri Pharmacy Association and is a subject matter expert with a fantastic group, the Community Pharmacy Enhanced Services Network, or CPESN, and she's health equity and the lead network facilitator for CPESN Missouri. Each state has a CPESN, and hopefully we'll hear some thoughts about expanding it here in Rhode Island. So Dr. Eisenbeis has developed a nationwide training specific for pharmacy technicians to be credentialed as community health workers and been able to promote, build, and sustain opportunities for pharmacy teams in my favorite two things, public health and chronic disease management. Thanks for joining us today. Tell us a little more about yourself for our listeners.
Absolutely. So thank you first for so much for having me. I am a pharmacist by trade, but have really dove into the public health space recently in my role at the Missouri Pharmacy Association, primarily because the pandemic especially opened the door for pharmacists in public health. Before that, we were really saying, pharmacists need to be involved. Pharmacists need to be involved. We can do so much in all of these different spaces, and we're embedded within our community. So it made sense. Now I'm saying, why not pharmacy? No one is asking why pharmacy anymore. It's really, why aren't we using pharmacy? Where are the pharmacists? Let's bring them into this space. And so that's where the community health worker course came into play, was really building those pharmacy teams and connecting those dots. I love dot connecting. I say that's really my primary job description, is just connecting the dots. So as the Director of Practice Development, I oversee about 7 of our grant opportunities with various departments, whether it's the Department of Health and Senior Services and the CDC, or we have HRSA grants, and then some more local grants as well with the Missouri Foundation for Health and the Board of Pharmacy. And all of them are really just finding ways to connect the dots, whether it's in public health to pharmacy, or pharmacy to pharmacy, and kind of all of that.
Well, thank you so much for that introduction. We are so excited to learn more about all that you do. And so to get started, let's, in your words, connect the dots a little bit on what community health workers actually do. And so just for our listeners, let's talk a little bit about that background. So community health workers are essentially members of the community that can work in vastly different settings. And the bottom line is to improve population health. So some of the services that they offer can include things such as interpretation and translation services, culturally appropriate health education and information, and even social support as well. Even things like transportation assistance and even connecting people to get care, whether that's medical or non-medical, is a really other important point of what that they do. Case management, risk identification, patient navigation, those are all other services that a community health worker could provide. And as we all know, the importance of these services really are so critical and can most definitely lead to improved outcomes and access for individuals that are aided through these services. Now, Annie, you definitely have a very strong background in working to promote these community health workers. We'll call them CHWs potentially for short, and especially these CHWs in pharmacy setting. So just so listeners can get a more expanded background, how would you describe the work that a community health worker does?
Great question. I think of pharmacy primarily as primary care or specialty extenders. So we're, like I mentioned earlier, embedded in our communities. We are really the value that pharmacists can bring. In my opinion, the biggest value that we can bring is in our follow-up and monitoring skills. So the fact that patients continue to come to pharmacy, we're embedded in all sorts of settings in addition to the community. And we have a reason that they keep coming in the door. So we have these additional touch points that other providers or other social care extenders even do not have. And so it just made sense to also have a social work extender in our communities. And that's really what I think of as a community health worker. They can play a variety of roles, but it's a lot of things that our pharmacy technicians were already doing. They were already flagging patients for needing additional support. They talk to patients often because, like I mentioned, they're coming into our doors for more than just care. They're coming in for their medications, over the counters. If you're in a grocery store chain, they're coming in for milk and eggs. So you're getting to touch those patients and talk to them in a different setting without that white coat syndrome, so to speak. And they're able to have these conversations. So our technicians are really able to do a deeper dive into those social determinants of health and screening and assessing for barriers to care outside of health barriers specifically. So I always use this as an example. I'm on a Facebook group called Work Together in Our Community, Columbia, Missouri. And when I present on this topic, I'll go back maybe a week and say, what are the things that our community is in need of? Because it's really just a place to say, hey, I'm searching for this. Does anybody have this? Or I need, access to transportation. Can someone give me a ride? And just opening that up to our smaller community here. And I usually don't have to go back a week. I can go back 24 to 48 hours and have plenty of posts to share that community health workers can actually have an impact on. So there's some that are related to vet bills, or some that are, again, related to transportation or food insecurities. And then there was recently a homeless camp that was removed from our city grounds. So trying to find access and care for the homeless in addition. And even the Wall Street Journal recently had an article about veterans and food insecurity. So these are all things that will impact health more so than even genetics or other kind of healthcare risk factors that we primarily think of. And so this is where the community health workers come into play. And again, it just makes sense in a community pharmacy, for example, or in a pharmacy setting, especially those that are in those rural areas that might not have other touch points or access to medical care. We have a reason that patients are coming in the door, so we have a reason to also support all of their other needs in addition.
That's wonderful. And I really like what you said about how they're already coming in for other reasons. And so that's already a great touch point that you have right there. And to think that you're getting someone while they're already there and not asking them to go across town for another appointment with a social worker, I think that's such a great kind of foundation of what community health workers are at their core. And so to kind of move in deeper with this topic, how do you think some of these tasks augment what a pharmacy technician already does in their work? And how might a community health worker in a pharmacy setting may differ from any setting outside of pharmacy?
Yes. So our community health workers, I say, are a little bit different than other settings that may have community health workers. And that's because as a pharmacy technician, just by virtue of the laws and rules and regulations that govern pharmacy, you are always 6 feet away from a clinician at all times. And that is not the case for other community health workers. So they're always 6 feet away from a pharmacist in a pharmacy. So whether they need kind of that clinical knowledge or judgment, or being able to refer to a pharmacist for additional care before even referring to other healthcare providers or other social needs and resources, that is something unique in a pharmacy setting, that they will always be right there and have that access to that resource. Additionally, that our pharmacy technicians probably already know a lot of the resources available to patients in their area, but through the course and credentialing as a community health worker, such as through the CE Impact course that's specific to pharmacy technicians that we help develop, they are able to create a resource binder. And we really think that that's the biggest value to the community health worker pharmacy technician in their dual hats. They create this resource binder. So they actually do 60 service learning hours in addition to the course. And we recommend having at least 30 different meetings with, various referral sources in their area. And most hit that or more because they find all of these different avenues of help that people are needing in social care or behavioral care or environmental help. And so we recommend different ideas, but then the group and the cohort of community health worker pharmacy technicians coming together and saying, well, this is where I went, or this is who I reached out to. They're able to develop binders that are specific to their area as well. And they then have that connection. So in those service learning hours, they reach out, they have a conversation about the referral sources and have the contacts available there. And so that resource binder is invaluable. Additionally, think about all the flags that we can kind of throw up as we talk to a patient, all of the needs that come up in just a drop off and pickup moment. And so being able to refer to that resource binder and have the tools necessary and the contact at that location makes it really valuable. Additionally, I think our pharmacy technicians already do this a lot more often than they think in that care coordination, or even when you just make a phone call to the insurance company and you're bouncing around for the patient trying to figure out why their copay is so high. We do a lot of these things already. So I think pharmacy technicians will find as they go through this course that they're just kind of adding a hat that other providers or other partners may recognize more so as far as what services they provide, but they're already providing a lot of these services.
I think it's really interesting because in the work that I do in addiction, we always say, it's not just the drug, it's everything else. And we have talked about expanding some of the things we do in that collaborative environment and how important it is that pharmacies provide addiction care because they're in those rural areas. There isn't access to services. There's that access and accessibility, but you got to manage all the other things. And so that binder concept's interesting. But I think it's also interesting is that having technicians trained is that they're in this brick and mortar place. You talked about earlier the pandemic changing things. And so I was thinking, well, why aren't people just telehealthing in? But these folks don't have phones or minutes on their phones, right? Or they don't have transportation. So if they can get to the pharmacy, it's sort of, you have this moment, you said like this pick up and drop off. There's 2 moments. People see pharmacists, twice or 4 times as many times as their primary care if they have primary care, right?
Right.
So how is this different than like calling, I don't know if this is in all areas, but like 311 for services, or I don't know if your county or state has like a number to call for services, or is that tailored environment, that binder so much more important in that way?
Yeah, so I think it's kind of twofold. You have one path that patients are not willing or maybe too proud or don't know that if they call this number, they're going to have resources available specifically for their needs. Sometimes they're basic needs. So we've had a pharmacy technician, there's a story of one that the patient just couldn't get out to get her medications because the person who normally raked her leaves had left, and she didn't know who to call to rake her leaves. And she was elderly and not comfortable enough, walking out to the bus stop to take the bus down to the pharmacy with all these wet leaves in her yard. And so the pharmacy technician, CHW, was able to find someone to come and rake her leaves. And that's all it took to pick up her medications on time. But it's something basic like that was limiting her. And I don't know if she called the number that I think it's 311 here as well, if they'd be able to provide a resource like as simple as that, or what we would think is as simple as that. But that was really a big barrier for her in getting those medications. I think too, like you said, I work in a pharmacy in rural Missouri. It's Sam's Health Mart as well, PRN. And we have patients that don't have cell phones, or if they do, they don't know how to work them. So I'll ask, let me put in your phone number so that we can call you when your medication's ready. Let me take out my phone, and the phone number is stuck to the front of the phone because they're not sure, because they don't use it enough to have the phone number memorized. And so we also have patients, like you said, that don't have transportation. We've had a patient come walk to the pharmacy, and one of our amazing delivery drivers drove him home. Now imagine too, those pharmacies that have that access to the patient's home with delivery drivers. We have had community health workers partner with their delivery drivers in pharmacies and go and actually provide home visits for things as well.
That is incredible. I think all of those are really great examples of what value these community health workers can bring to pharmacies, and really just expanding upon the point that community pharmacies are so essential to public health in every way. And I think having these services just drastically increases that value for sure. And so I wanted to jump back to something that you had mentioned before about the credentialing process, and you had mentioned training and service hours. So I would love to know a little bit about what the credentialing process is for a community health worker and who maybe beyond pharmacy technicians are the ideal candidates for this.
So state by state is all different. Now, that doesn't mean that we're not trying to navigate every state with our course as well. When we actually started this kind of project about 4 years ago with a pharmacy in Southeast Missouri, LNS Pharmacy. I'm sure listeners on here will have heard of the Logans, Trip and Richard Logan. They have phenomenal ideas for serving their community, and it's a community of great need. And so they sent a couple of pharmacy technicians to the local community colleges that also have community health worker courses. And they said, it's not really specific to the pharmacy workflow, and implementing it back into the pharmacy was a little bit more difficult. And so that's when we had this idea to have some of our leftover grant funding develop this course. And now once we had this course developed, it was also a very quick turnaround time. Their clinical pharmacy director, Bianca Daisy, did a phenomenal job, because I was like, we have 2 months to spend this grant funding. And she's like, okay, I'm going to dedicate 2 months to create this course, at least the outline and content of the course, to get it approved by our state. Because in Missouri, similar to several other states, we actually have to have our course and providership of the course credentialed by the state as well. So they can't just take any community health worker course. It needs to be approved and credentialed by the state and Department of Health and Senior Services here. So she was able to create that outline and content and syllabi and everything needed for the course to get it approved by the state. And after it was approved, we said, this is probably a lot bigger than just Missouri and could help a lot more patients than just Missouri patients. There's probably patients like the woman who needed her leaves raked all over the US. And there's no reason that pharmacy technicians or pharmacy teams cannot support these patients. Like we've known in other public health crises, like a COVID-19 pandemic, pharmacists are able to step up and pharmacy teams are really able to step up. And so we reached out to CE Impact. We'd had a couple conversations about how do we take this and make it nationwide, considering as well that this is going to be a different credentialing process potentially in every state. And some may need advocacy efforts as well to push the credentialing process forward or change the credentialing process. For example, some states it's under their Board of Nursing. And so we'll have to kind of maneuver working with the Board of Nursing to do that. And that's definitely something we were willing to do, but it just kind of looked, even just the optics of saying we're the Missouri team looking to credential this everywhere. So CE Impact took the course and made it beautiful, made it organized in their virtual learning platform. They were able to have it not just be virtual though. So it's their learning platform allowed you to have conversations offline. And then we still have a live course every Tuesday evening for 16 weeks. And then CPSN Health Equity, a special purpose network, just recently started and has launched and has kind of also supported these efforts as well. With CPSN pharmacies able to credential community health workers and help with those advocacy efforts and kind of grant efforts that involve pharmacists in public health and pharmacy teams. Anyway, so in the various states, it's all different, but we wanted it to be bigger than just Missouri.
That is so wonderful, being able to kind of translate this training course that you originally started for your state and then expanding it onto a nationwide level. That is, first of all, so impressive and also so valuable for those people going through that training course and the value that they're bringing to their communities because of that. I am so curious to hear, before the nationwide training program, before Missouri, how did you originally get started working with this effort in community health work?
That's such an interesting question, because I really sort of fell into this work and fell in love with this work at the same time. After being a pharmacist in the community setting for 5 years, in various, like at a grocery store chain, at an independent pharmacy in central Missouri, the Missouri Pharmacy Association opened up their first executive fellowship in association management. And I jumped at the position. I told my boss, I was the pick of a store in central Missouri at the time. And I said, I think I need to take this position. And he said, I know I can't stop you, because it would have been something that he would have loved as well. He was a very involved pharmacist. And so I took this executive fellowship position for a year. And at the very first staff meeting, I think it was the first day of my fellowship, I said, so I plan to be here after my fellowship ends. So give me any and all work that I can do that you don't want to do, or that I can take on for you. And so on day one of the fellowship ending, I had at least a part-time position here at the Missouri Pharmacy Association, overseeing one of our grant opportunities that was mostly related to diabetes education and accrediting pharmacies for diabetes education, with the caveat that if I were able to find additional grants to fund the rest of the position, so the other 50% of my time, I could be full-time. So within 3 months, there was enough public health need to go around for pharmacy and myself in Missouri. And I was full-time within 3 months. And that's within two grants. So we had one in diabetes education and one specific to an innovation technology pharmacy team in the St. Louis area. And since then, our grants have grown tenfold. Again, the pandemic really silver lining was opening doors for pharmacy support in public health, all public health initiatives, not just vaccinations. So while we do have an immunization grant, we have a community health worker grant. We have a grant that supports kind of our CPSN infrastructure, even to be able to support sustainability. So partnering with Missouri Medicaid, for example, or other partners for various support, whether it's Randolph County Caring Communities or the Missouri Foundation for Health, and looking at all of these different opportunities there. So again, it hasn't just been about community health workers. It hasn't just been about COVID-19. It's really been about what the impact is that pharmacists and pharmacy teams can bring to the table. And I really highlight pharmacy teams because the CHW model involving pharmacy technicians has not just opened doors for pharmacy technicians in Missouri either. It's really opened doors for pharmacy businesses and for pharmacists as well, to be able to share what services pharmacists bring to the table as well. So when we talk about partners or payer opportunities, they know what community health workers do. They're still sending us to PBMs when they hear pharmacist services. Now, CHW gets our toes in the door, though, to say, well, our CHW does this, and if you add them into your network or your team or your payer opportunity, we can also add pharmacist services. And here's what those now provide: that monitoring and follow-up value, for example, the medication review, medication optimization, all of the additional care coordination that a pharmacist can bring with a community health worker pharmacy technician.
This is just great. You touch on all the things that we like to talk about on the podcast here, and that I like to do in our community work across the state, and former president of our association, and doing all these kinds of promotional things. But I just have one potential limitation. So all this sounds great to payers, and we want to get more in depth in that. But are technicians interested in doing this? Because you're sort of building this. Are there community health workers who are like, I want to be in the pharmacy, and how do I become a tech? Do you have technicians saying, I want to do more? Or do you have technicians saying, whoa, I didn't sign up to do this. I want to just talk about medications. Like, what's that sort of person environment that you're seeing in Missouri or in other places?
Great question. So we probably have a bucket of all of them. Just like in any opportunity, you're going to have your early adopters, and then kind of that bell curve, so to speak, and your late bloomers, maybe. I will say, I think in Missouri, at least, we do not require certification of our pharmacy technicians. So the requirement would be to register with the Board of Pharmacy, which means you fill out an application and you get your fingers printed with a background check, and you can work in the pharmacy while that is even being reviewed. So as long as you post that you submitted your application, you can work in a pharmacy under pharmacist supervision. Which is also very limiting for our board then to say, well, pharmacy technicians cannot do much more than X, Y, and Z. There's no clinical decision-making whatsoever. That's understandable. But there's no education. If they're trained as nurses or dietitians, they're not allowed to do anything more in a pharmacy. Now, that recently changed. That was for the last 4 years as we're developing this community health worker pilot and program. Recently in January, our board of pharmacy said, well, we've seen a lot of data and evidence from various programs, including our CHW course. And we are looking at, now I think technicians should be able to provide education, for example, such as diabetes education, diabetes prevention, SMBP, doing blood pressure screenings, as long as they are trained and under a scope of another board that allows them to do this, such as the Department of Health and Senior Services or registered nurses or dietitians, for example. So now they can wear these multiple hats if they have the credentialing and training required. So I think our pharmacy technicians originally probably had less of a career ladder and an opportunity to partake in a lot more patient care elements than they do now. And the community health worker course and credentialing opens that door. I think it also opens the door for including them in more conversations related to pharmacy services and sustainability. So we've had community health workers that are really the point person for finding partnerships or finding payer opportunities or helping their CPSN pharmacies, for example, go to employer groups and say, this is what I do in my pharmacy and what I can do for your patients.
I think that's such an incredible way to look at it. And I really liked what you said earlier about really taking this more as a holistic view of a pharmacy team, not just technicians, not just pharmacists, not just pharmacy interns. And to kind of circle back, we were just talking about all of the increasing services and increasing hats that all of these people in the pharmacy wear. And so with all of these increasing numbers of services offered, I feel that it's very important that these workers are adequately compensated. And so billing and payable services is probably a question you must get asked very frequently in relation to this program and community health workers. So would you be able to tell us a little bit about the reimbursement process for these programs?
So this also probably depends a little bit on your state. So for example, in Missouri, our Medicaid program is carved out of our managed care. So for pharmacy, so we typically do not bill managed care for many services without contracting specifically, such as DME, for example. Our pharmacy is all fee for service. Even our Medicaid MTM opportunities are under our pharmacy benefits. And so pharmacists in Missouri can enroll as providers. Community health workers cannot. However, there's a lot of opportunity for them to support the pharmacist in a lot of these endeavors, and then have opened doors for our pharmacies in partnerships outside of payer opportunities. Now, when you work with managed care organizations, a lot of them in other states do pay for social determinants of health screenings, for example, by a community health worker or a pharmacist. And additionally, like I mentioned, that our pharmacy techs who are community health workers can provide education now. So they can do DSME or DPP, SMBP. There are things that pharmacies can bill for service-wise, and the community health worker adds an element to that ROI. They also add an element to those conversations when we're trying to get our foot in the door for a contract or get our foot in the door for an opportunity or a grant. If you mention that you have a community health worker in a pharmacy, now we're having to say no to grant opportunities because we don't have the capacity for them. And our grants that we do have gone from, $250,000 for the whole state of pharmacy to $900,000. So it's just kind of a crazy opportunity boost, just because other partners understand what community health workers do. And then we're just layering on top what the pharmacist does and should be able to bill for. So really, I see community health workers not necessarily as a huge reimbursement model in and of themselves. Again, it's that pharmacy team. So it's more in the value that they add to the ROI at the end, or the value that they add because your patients have better outcomes because you're not just addressing they're not taking their Lipitor on time and they're not adherent. It's addressing all of those other issues so that your pharmacy can have higher ratings and higher metrics and achieve better metrics as well, especially for those communities that are in the highest need.
And my question was going to be about metrics and meeting quality standards and all those things. So that's definitely there. And I mean, it's similar to how I think, again, 10, 20, sometimes 30 years ago, adding pharmacists to primary care, right? Not really reimbursed, not a reimbursable model, but it became a point where pharmacists got diabetes metrics to a point where now you're in the highest category of reimbursement and it pays for their salary, right? Or pharmacists being added to hospitals doing antimicrobial stewardship. Now there's a requirement to have them, but they were saving so much money that it was just happening anyway, right? So
Yes.
yeah, so it's really interesting. Some it's this sort of trickle down and people work collaboratively. Now, people are probably listening to this going, oh my gosh, I hope people are listening to this going, okay, when I go to my pharmacy, the pharmacist is so busy they have no time to talk to anybody. So I'm sure workloads are similar in Missouri, right? And other places where your work is going. What do pharmacists think about this training? And it sounds like the technician model is different there than in other places where there has to be some education and things, or technicians can do more things. Like here, they can immunize in Rhode Island, even after the public health emergency and before it. What are pharmacists thinking, that this is actually time saving, or that, gee, there's fewer adherence problems because they're helping us meet these metrics? Like and you mentioned this earlier about workload, like what do the pharmacists think about the technicians are becoming CHWs?
Great question. So pharmacists are probably more excited about their technicians becoming CHWs than some of the technicians are in becoming CHWs. I think because they've seen this work in public health spaces involving pharmacists, and now they're really wanting to expand that capacity. And so being able to include the entire team makes it more efficient, more consistent, more effective. They're able to even look at building services on things that they already do really well. So we are looking at programs that build on top of like our pharmacies with strong med sync programs, and using those calls every month to the patient to do screenings, and utilize your community health worker in kind of as a resource in those calls as well. So you can have your pharmacy technicians continue that med sync process. Our calls are maybe done by the community health worker who flags and refers to the pharmacist. So things are really kind of escalating to the point of referrals that they should be, versus everything falling on the pharmacist or everything falling on the technician. It's really a team-based approach, just like in any other kind of care approach or model. We want to use that team-based approach. And I think it's more exciting to have pharmacy technicians who have a little bit more buy-in to the patient care and care coordination as well.
All right, we got a couple more questions. You get to think of the ideal now. What is the most equitable reimbursement strategy that puts CHWs in all pharmacies? So let's not think of state differences, or think about the places where you've worked where you're like, I wish that could be here and everywhere. What would that look like to you?
Ooh, that's a great question. For reimbursement wise, I think the value of the CHW in the pharmacy also ties in the pharmacist. So I can't leave out that the pharmacist should also be able to get reimbursed. But I had this idea a while back. And I'm kind of sharing it with everybody to see who can pick it up and do something with it. So when I was getting my MBA, in my entrepreneurship class, we had to come up with a big idea. And my big idea, being a pharmacist and passionate about advocacy and pharmacy services, was that you have your primary care physician. Why do you not have your primary care pharmacist, your PCP and your PC Pharm? And I think if you have a primary care pharmacist, and that's not just the pharmacist doing MTM, and that's not just the pharmacist providing additional services, it really is the model of primary care going into the communities and kind of having that access to bill in primary care as well, or with primary care services in the pharmacy setting. And I think that tied with a community health worker in the pharmacy setting would just would definitely be a game changer. Having the pharmacist providing primary care and the pharmacy technician providing those social determinants of health and health equity support would be a big benefit to patients who don't have access otherwise. And just the social combined with the primary care would be phenomenal. So you have your PC Pharm, your PCP, and your CHW pharmacy technician all able to bill. Now, when I say able to bill, I also think that a part of that billing model needs to be the collaboration between all of the pharmacy, PCP, CHW, specialty providers as well. So in my ideal reimbursement model, there's also an ideal communication model. So not just getting paid for your touch point or your intervention or fee for service, whatever that model looks like. It doesn't matter if we're not able to communicate what we did effectively. So I think fax, not really sure how old fax is, but I know it's pretty old compared to other forms of electronic communication. So I don't think fax should be the most reliable for pharmacy or healthcare. And I don't think fax should be the kind of go-to communicator. I think we do need some sort of health information exchange or somewhere that we can access mutual patient data to be able to support their care in the most comprehensive model. And there are some platforms that are doing this for different pockets of things. So there are platforms doing this for specific social determinants of health referrals. But imagine combining those with our health information exchanges or our vaccine registries, for example, and being able to access that data when you're speaking with a patient and then know all the things you need to know to be able to give them the best resources possible.
Yeah, it's interesting. I think about in Rhode Island, the work I do with our Department of Health, that there's a database of people who have history of being unhoused or unstably housed, and there's different definitions for that. And I'm sort of like, what if a pharmacist knew about that? Like, what if, I mean, we are under HIPAA, and the interesting thing is like, well, if I'm the community pharmacist and I'm just trying to get the right prescription to the right, person, I can't even think about those things. If I have that community health worker and I have the documentation with the primary care physician and maybe I've got access to specialty pharmacists and specialty providers, but most importantly, I have that CHW to say, like, here's somebody you need to talk to, then again, that information can be used, right? And so I think that's a really, really fascinating thing. And we'll have you back when you've mastered that in a few years.
Or someone
1 year.
else.
We'll give you 1 year, and then we'll have you back to tell us about how we're gonna model this.
Sounds good. Challenge accepted.
Okay. So Bryn, what's the regimen for community health workers and pharmacies?
I think that the regimen for community health workers and pharmacies is really just that, getting more community health workers in these communities, and especially those communities that need them most, to be honest. I think what you said earlier, Annie, about having this whole pharmacy team be involved in the entire aspect of patient care, which is not just filling their prescriptions on time, but really making sure that we're working to improve their social determinants of health and really doing everything that we can to not only manage their medications appropriately, but also give them the resources that these patients need to succeed and live a healthier life. I think that really, based on our conversation today, we know that pharmacy is so much more for public health than giving vaccinations. It is so much more than just harm reduction. There is so much that we could be doing. And I think with that being said, even while ideally we would love to have community health workers in all the places that we could, I think it's really important that listeners take away from this today. Take what you can from this episode. One thing that you were talking about before with the binder, with all of the resources, I don't think you have to be a community health worker to make some resources and collect that information together to have on hand for your patients. And so I think just really doing what you can with whatever resources you have to make life better and more equitable for your patients is a great start. But then definitely working towards advocating for community health workers and pharmacies is a great step that we could be taking to improve the health in our communities. So I think that wonderfully wraps up this episode of The Regimen today. And this really has been an incredible discussion. And so I'd like to thank our guest, Dr. Annie Eisenbeis, for being here once again and for sharing her expertise in this topic. I knew before this episode that you were very passionate and had a lot to say about this topic. And I think after talking to you, so am I as well. And so I'm so excited for this episode to go live and to really share this message across our channels.
Thank you so much for having me.
Yes, it's been wonderful, and I should really acknowledge the annual meeting of the American Pharmacists Association and the NASPA meeting and those folks for allowing me to meet Annie and invite her and graciously offering her time for us here. So Bryn talked about sharing. Be sure to follow us at PharmD Pub Health on Instagram. I know we stole that from you, Annie. I know you wanted that one, but we'll figure it out. We'll have
Maybe the Mo Farm.
Yeah, we'll do that. So follow us at PharmD Pub Health on Instagram and Twitter. Turn on post notifications so you never miss an episode, and smash that subscribe button now on Spotify, Apple Podcasts, our YouTube channel. That's also at PharmD Pub Health, Amazon Music, or wherever you listen to podcasts. Thanks so much, everybody.